Clinical investigation reveals the axilla as a high-stakes anatomical transition zone, housing a dense and pulsating vascular network beneath the surface of the shoulder. It occupies the precise junction where the thoracic wall bridges directly to the upper limb. Because the shoulder is the most mobile joint in the human body, the tissues connecting the chest to the arm face extreme physical demands, requiring a dedicated and protected routing corridor. Major blood vessels, the peripheral nerves, and lymphatic drainage systems all rely on this specific passage to traverse the torso-limb boundary safely. Routing these fragile systems across a high-motion joint requires rigid structural boundaries to prevent mechanical compression during movement. This highly engineered physical container provides the structural integrity necessary to maintain upper limb survival. Anatomical literature defines this space as a pyramidal-shaped region situated between the upper arm and the side of the chest wall. Medical mastery of the region begins with a geometric mental model, a four-sided pyramid. This structural model consists of a superior apex, an inferior base, and four distinct walls that enclose the neurovascular contents. Unlike a perfect pyramid, the axillary space is truncated at the top and positioned obliquely against the ribcage. This schematic maps the theoretical boundaries onto the body, establishing an anterior wall in front, a posterior wall behind, and medial and lateral limits on either side. Visualizing this abstract geometric box allows a clinician to accurately predict the location of hidden structures during surgery or high-impact trauma. The structural build begins at the apex, which is directed upward and medially toward the root of the neck. It is bounded by the clavicle, the first rib, and the superior border of the scapula. Anatomists refer to this specific triangular gateway as the cervicoaxillary canal. This canal serves as the entry point for all major vessels and nerves passing from the neck into the arm. At the opposite end of the vertical axis sits the base, or floor, which forms a convex curve pointing upward into the axillary space. This floor is composed of skin and superficial fascia, supported by the specialized axillary fascia. The base stretches between the two physical landmarks of the shoulder, the anterior and posterior axillary folds. The relationship between the apex and base creates a sealed vertical tunnel, dictating the one-way directional flow of the internal neurovascular bundle. The anterior wall is formed by a multi-layered muscular arrangement led by the broad pectoralis major. Beneath the pectoralis major, the clavipectoral mascia and the pectoralis minor muscle complete the front boundary of the pyramid. The posterior wall begins with the superior border of the scapula and the medial aspect of the coracoid process. Deep muscles, including the subscapularis, form a thick protective barrier that closes the space from the back. These anterior and posterior walls do not run parallel to each other as they extend away from the torso. Instead, these massive muscle groups converge sharply as they move outward toward the humerus. This dramatic convergence creates a structural pinch point, forcing a wide proximal space to narrow significantly as it reaches the arm. The medial wall is a broad, rigid surface formed by the outer border of the first rib and the thoracic cage. This wide medial base contrasts sharply with the lateral wall, which is extremely narrow due to the convergence of the muscle groups. The lateral boundary is restricted to the narrow channel of the bicipital groove on the humerus. The coracobrachialis and the short head of the biceps muscles overlay this groove to finalize the lateral wall. The completed geometry is a rigid chamber at the chest wall that funnels down to a tiny, crowded groove on the arm bone. With the physical scaffold established, we can examine the dense, complex structures packed within it. This cross-section serves as our clinical map. We identify the anterior pectoralis muscles and the lateral humerus. Centrally located are the axillary artery and vein. Wrapped tightly around the artery are the cords of the brachial plexus, forming the critical neural wiring for the arm. An axillary sheath bundles these vital lines together into a single protected unit. Axillary fat and areolar tissue fill the voids, cushioning fragile tubes against the rigid muscular walls. In this dense arrangement, an enlarging artery immediately compromises the surrounding nerves because there is no empty space for expansion. The axilla also functions as a critical biological filtration center and a routing hub for disease. Axillary lymph nodes are scattered throughout the fat, filtering fluid from the limb and torso. The axillary tail of the mammary gland protrudes into this space, overlapping with the lymphatic network. This specific combination of mammary tissue and lymph nodes makes the axilla the primary surgical site for breast cancer staging and metastasis tracking. Because of the lateral pinch point, any swelling in this confined space directly threatens the blood supply and innervation of the entire arm. Mastering these rigid geometric boundaries is the only way a clinician can safely navigate, diagnose, and repair the neurovascular highway hidden within the axilla.